Our final presentation today before our Community Voice panel will be from Dr. McCormack from Children's Hospital of Philadelphia. Dr. McCormack is an attending physician and scientific director of the Neuroendocrine Center in the Division of Endocrinology and Diabetes at Children's Hospital of Philadelphia. She is also part of the Friedreich Ataxia Center of Excellence and Mitochondrial Medicine at CHOP. She is an associate professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Thank you so much, Dr. McCormack, for being here today. And I will now turn the time over to you.
I really appreciate the invitation to speak with the group, and it's always fun to follow Dave Lynch, with whom I work really closely, who's taught me a lot about Friedreich ataxia, and it's just a privilege to work all together. So I've been asked to give a talk on endocrine complications of Friedreich ataxia. We're going to focus on diabetes, on problems with growth, and problems with bone health. For those of you who've heard me talk about this before, I hope it's a mix of some review and reinforcement, because there can never be too much reinforcement, and also some new information for you. And I look forward to people's questions either at the end, or folks can reach out to us separately if they have different questions. So diabetes first. This is the very basic slide. We don't want anyone to leave this talk without knowing what symptoms of diabetes can be, because diabetes is a complication that can occur in Friedreich's, and it's a manageable complication. So we don't want people to suffer needlessly if they have something that can be treated. So this is a slide from a UK group that talks about diabetes that I really like because I think it's memorable. So when blood sugar is high in diabetes, in particular when blood sugar exceeds around 180 or 200 milligrams per deciliter, we're going to talk a little bit about numbers just because people will see those on their lab results. So we want you to be a little familiar. So when blood sugars are high, above 180 or 200, they cause sugar to spill into the urine. And when sugar spills into the urine, it makes you pee a lot. So you go to the bathroom more, and not just more frequently, because we know that urinary frequency can happen in Friedreich's, but there's a larger volume of urine. And so because there's a larger volume of urine, people become thirsty because they're somewhat more dehydrated. Higher blood sugars also can affect energy levels. So we know fatigue is really prevalent in folks with FA. So this would be new or worsening fatigue. Higher blood sugars from uncontrolled diabetes should be a symptom on the checklist, something that can be checked off quite readily with lab testing. Unintentional weight loss, so peeing lots of sugar into the toilet is not a great way to lose weight, but it is one way that people's weight goes down in a way that's surprising. That's despite eating around the same amount. So this slide reminds us is if those symptoms are present, then one should get tested. There's also testing that's routinely recommended for individuals with Friedreich's because diabetes is more common in folks with Friedreich ataxia. So at the end of the talk, I'm going to include a slide that you can share. You can look up yourself. You can share with your physician team about diabetes screening. But the guidelines say that every year, individuals should have a hemoglobin A1C measurement as well as a fasting blood glucose, blood sugar. Hemoglobin A1C, to remind folks, that's a measurement that reflects the average blood sugar over around 3 months. So hemoglobin you will have heard of, it's the molecule found in red blood cells. Sugar in the bloodstream sticks to the hemoglobin molecule. So if there's been a lot of sugar around, that molecule gets a little more sticky, and the average blood cell lives around 3 months. So the reason that hemoglobin A1C measurement is useful, either for screening or for folks who have diabetes, is that besides telling us what the blood sugar is this minute at one single point in time, hemoglobin A1C gives us a sense of how high the blood sugars have been over 3 months. Also, potential longer-term complications of diabetes are associated with higher levels of hemoglobin A1C. So those are the blood tests that we recommend get done each year. And of course, education about symptoms so that folks, you needn't only be screened for diabetes, once a year. If people have symptoms in between their annual screening, they should absolutely reach out and get tested because we really don't want anyone to come in really sick from diabetes because it's preventable. So I'm going to tell you a little bit about Friedreich's related diabetes, just one slide, and then go into some scenarios about some screening testing results that we sometimes get that folks who are watching or now or on the recording, folks who are watching may have gotten themselves, so you can know what to anticipate if you get abnormal screening results. So when people, this is a question I get a lot when people are saying, well, what kind of diabetes is happens in Friedreich's? When we say, 10% maybe of individuals with Friedreich's develop overt diabetes. Many more have subclinical abnormalities in blood sugar, meaning if you do additional testing, blood sugar metabolism is not normal in many other people with Friedreich ataxia. They say, is it type 1? Is it type 2? And my own practice, and this schematic shows this, if blue people are people without diabetes, red are people with typical type 1 or type 2. I think of people with Friedreich's related diabetes as those in green. Like Friedreich's related diabetes is its own entity, and I call it Friedreich's related diabetes, right? So type 1 diabetes, just a brief primer so that people review. I think these names would probably be better be retired because they don't necessarily tell us what we as doctors need to know completely about managing people. So many people, when they say type 1, they mean requiring insulin. But people with all kinds of diabetes can require insulin. So technically, type 1 diabetes is what's called autoimmune diabetes, meaning diabetes caused by the immune system for reasons we don't entirely understand. Instead of attacking bacteria and viruses, attacks the body's own insulin producing cells, so the person can't produce insulin anymore. So the treatment for autoimmune type 1 diabetes is insulin. And that's the diabetes that shows up more often in childhood and is not caused by differences in eating or activity. Type 2 diabetes is more common and really heterogeneous, really different between people. In general, things like inactivity, carrying excess weight can contribute to type 2 diabetes risk, as can advancing age. But there's also a strong genetic component. Some families have a higher tendency to develop type 2 diabetes. And many people with type 2 diabetes will end up requiring insulin, not all. There's lots of other medicines that can be used to manage that as well. So when we think about Friedreich's related diabetes, kind of like where does it land between these entities or aside from these entities, right? So when Friedreich's related diabetes shows up in children, it does have a lot of similarities to autoimmune or type 1 diabetes because Friedreich's affects the cells in the pancreas that make insulin. So children show up with insulin deficiency in many ways similar to children with autoimmune type 1 diabetes. And they show up with higher blood sugars, which made them dehydrated. If insulin deficiency has been going on a little bit longer, then it can cause something called diabetic ketoacidosis. That's where the body is in essentially a state of starvation because insulin can't put sugar into the tissues. And so the body ends up in an uncontrolled way burning fat for energy. And that generates ketones. That process causes a buildup of acid in the body and can make people really, really sick. So children with Friedreich ataxia related diabetes can show up in diabetic ketoacidosis. And we hope they don't. We hope that this sessions like these and routine screening can prevent that. There's also some differences when children are diagnosed from typical autoimmune type 1 diabetes. And one of the most notable, excuse me, is negative pancreatic autoantibody studies. And what are those? Those are blood tests that look for evidence of autoimmunity. So it should be illegal to have two problems. You shouldn't, have to have Friedreich ataxia plus autoimmune type 1 diabetes, but it could be possible. So our own practice at CHOP, and I recommend this elsewhere, is if children with Friedreich ataxia have diabetes, we do the pancreatic autoantibody testing. In all the children we've taken care of with Friedreich ataxia and diabetes, those pancreatic autoantibodies are negative, and that's different from typical autoimmune type 1. So that's an important set of tests to do to distinguish, and because that also has some therapeutic implications. So individuals with type 1 diabetes, currently, especially early in disease, there are medicines that modulate the immune system that can be offered to them that, of course, that wouldn't be appropriate for individuals with Friedreich's related diabetes, for example. When we think about adults with Friedreich's related diabetes, there are some similarities to what we might think of as garden variety type 2 diabetes, mostly that there can be some resistance to the effect of insulin. So insulin is that main hormone that controls blood sugar. It often in children, especially, there's deficiency of that insulin. There can also be relative deficiency of insulin if insulin has to work really hard to overcome resistance to control blood sugar. And what produces resistance is excess weight, older age, and inactivity. So adults with Friedreich ataxia can have some degree of insulin resistance, as occurs in type 2 diabetes. There's also some differences from type 2 diabetes. So adults with Friedreich ataxia will develop diabetes at lower levels of BMI, at lower body weights, and at younger ages than the general population. And they're also more likely to require insulin than typical individuals with type 2 diabetes. So Friedreich ataxia related diabetes does share some features of the types of diabetes you've heard of, but it really is its own entity, and so worth thinking about in a specialized way, because that's going to help us choose the most appropriate therapy. So before we go to therapy, I'm going to talk, as I mentioned, about some of the screening results we sometimes get and like what we do about them. So this is a result we got the other day, a hemoglobin A1C value of 6.3%. And what does that mean? So 6.3% corresponds to an average blood sugar of 134 milligrams per deciliter. That's what we can calculate on average. A normal hemoglobin A1C is less than 5.8%, so this is elevated. But an A1C of 6.5% or higher is diabetes range. So this is too elevated to be normal, but not high enough to count as diabetes. So this is in a pre-diabetes range, so somewhat abnormal, but not high enough to be called diabetes. So what do we do with that? So first we think about safety. Does this individual have symptoms of high blood sugar, like the excess thirst, like the urination? The reason that's important is sometimes the hemoglobin A1C number can lag behind the higher blood sugars. In other words, if the diabetes is developing quickly, the person's blood sugar currently may be more often in the 200s or the 300s, that level that can be dehydrating before it's really reflected in a higher A1C. So we first ask, is the person having any symptoms? Do we need to evaluate them more acutely? We always, as I mentioned, test anti-pancreatic autoantibodies to look for evidence of autoimmunity. Is this type 1 diabetes and not Friedreich's related diabetes? We do that to be complete, and also because we know if there's autoimmunity that an individual will need insulin essentially right away. And then we do some additional lab testing to see how much insulin is the person making. Is there evidence of insulin resistance? And my practice is usually to give people the option to measure blood sugar, so they have the ability at home to give us a sense of where our blood sugar is running currently. And then we may consider medications, which I'll review on the next slide. Oops. Here we go. So the first question we always get is like, what are the reasons for insulin? Or that's the first questions we ask ourselves. Many people are concerned about needing insulin, understandably. When insulin deficiency is the main problem, though, giving back insulin is the most helpful thing to do and makes people feel better quickly and makes them have better health outcomes. Insulin is an injectable medicine, I say that out loud, so and can have some side effects, so it's understandable that there could be reluctance, but if it's needed, it's absolutely the right thing. So anyone who comes with diabetic ketoacidosis, that's a serious complication of insulin deficiency. They need insulin. Significant dehydration or weight loss, then often we start with insulin. We may be able to come off in certain patients, but just to keep people safe, we may start there. Children, younger children in particularly, often are needing insulin because the type of diabetes they show us is usually pancreatic beta cell insufficiency or insulin deficiency. I show this every year when I give a talk on Friedreich-related diabetes. This is the American Diabetes Association guidelines for medication selection, and they update these every year. I show these here for at least two reasons. One is this is a detailed chart. As detailed as it is, it does not have a Friedreich ataxia category. There's a little bit of language around subtypes or unique types of diabetes, but not a lot. So the Friedreich's guidelines are still the best place for us to look. But then the second thing to take for this chart, and it's amazing how many more and more options we have to treat diabetes than we did when I was first in training. This chart is divided into two halves based on people's goals. So we have different medicines that we might use if weight loss is a goal in addition to managing blood sugars. And we have different medications we might use if there's cardiovascular disease or kidney disease. Weight loss is relevant in some adults, in particular with FA. Some folks may have weight loss as a goal, a decision that's made in collaboration with their usual team, obviously. And in particular, if there's individuals with heart failure, there are some medicines that are used to lower blood sugars that may have additional benefits in people who have overt heart failure. So those are the times that we would be most likely to consider non-insulin medicines, where if weight loss was the goal, and you've heard of the GLP-1 receptor agonist medicines, really popular at the moment, Ozempic, Mounjaro, those are types of injectable medicines that control blood sugars and also produce weight loss. And then for folks with heart failure or significant cardiac disease, the SGLT2 inhibitors and medicines that end in glyphosine, so empagliflozin, canagliflozin, those are medicines that may be helpful. For each of these, we have to balance specific risks and benefits. GLP-1 receptor agonists come with a lot of nausea and vomiting. We also worry about, with weight loss, whether or not muscle loss will occur too, and whether or not that will have functional relevance. The SGLT2 inhibitors actually work in part by increasing urine output of glucose. So some people get urinary tract infections or fungal infections, which can be really unpleasant. Also with the SGLT2 inhibitors in particular, if someone's pancreas is not making enough insulin, they can predispose to diabetic ketoacidosis. So we do a lot of specific testing and monitoring to check for that complication in people with Friedreich's related diabetes. We definitely want to avoid low blood sugars and to avoid ketones in people with diabetes. There's the ability to measure ketones in urine or in blood, and we always do that in blood because it's more accurate in people with Friedreich's. And we've studied this and found that in some centers there's reluctance to use or to offer technology, meaning like continuous glucose monitors or insulin pumps to individuals with the rarer subtypes of diabetes, but our experience is these can be really valuable. Continuous glucose monitors, you've probably seen the advertisements on the TV. They can go up kind of like the upper arm. They can be a great way if people need more detailed blood sugar monitoring, in particular those with dexterity or vision issues, to have something on that can really easily give them a measurement anytime. So this is a different scenario, switching to a higher hemoglobin A1C. So now you're familiar with interpreting this number. A hemoglobin A1C in this range, in 11.3, so I told you 6.5 and up is diabetes. Our patients with diabetes, hemoglobin A1C values less than 7 or even in the 6 range are usually optimal for producing good health outcomes. So A1C of 11.3 is too high. That corresponds to an average blood sugar of nearly 300, also too high. So if I got this result, I would wonder, does this patient need to be referred to the hospital? Are they very sick or at risk to become very sick where we need to get lab information right away? We really want to check for diabetic ketoacidosis, electrolyte abnormalities, and significant dehydration if blood sugars have been this high. And almost always in this circumstance, we're going to be starting insulin. If other medicines reduce the need for insulin later, that's great. It really depends on the circumstance. And then monitoring those other labs, as I mentioned, to see how well the pancreas is producing insulin and can help us. And other medications, as we talked about. So that's the diabetes section of the talk, and then Q&A, we can absolutely talk more about that for folks who are interested. And then switching gears a bit to growth, this would be most relevant, of course, to folks with children who have Friedreich's, but you may have an interest, even if you're an adult, to reflect back on how your growth may have been affected by the condition. So growth and weight gain are really important. I'm stating the obvious. In pediatrics, we measure growth very carefully. So despite that, we've studied this and found that many children are missing measurements and literally missing the height and weight measurements that are so essential to determining growth. And Dr. Lynch was just talking about things like gene therapy. I mean, incredibly advanced, incredibly sophisticated technologies, stadiometers and scales are not as sophisticated, but they're still incredibly informative. So we really advocate that adaptive equipment be made available and that children, including those who are not able to stand unsupported, get measurements of their weight, including in, for example, like a wheelchair scale, or if they're not able to stand safely, with a length measurement so that we can follow growth the way we should. Adults also have missing measurement. Changes in weight are really important, so getting accurate weights and heights are valuable in adults too. I'm giving a case example here because this is a kind of case that we would see pretty often. We're referred individuals who have Friedreich's and may not be growing. So this is an example of a 14-year-old boy who was diagnosed with Friedreich's at age 7 and uses a wheelchair. Has cardiomyopathy, and his family raised concerns about growth. So we've plotted some measurements on the growth curve. We put height and weight together on this slide, and we consider them together because of how important weight gain and height gain are. So you can see this child was like kind of the lower percentile range and was growing consistently along their percentile and then started to fall off. And around the same time, the weight was stabilizing. So what do we do next? So what we do next is informed by the potential causes of less than optimal growth. And we do know that growth and puberty can be affected in Friedreich's, as they can in many chronic health conditions. And the way I think about this as an endocrinologist is that growth and reproduction are a luxury. So if the body senses that there's not enough energy available or resources available to devote to getting bigger or to reproducing, then growth and puberty can be affected in any number of chronic conditions. So when we see someone or we have raises concern of less than optimal growth, we always want to exclude common causes before just attributing poor growth to Friedreich's, right? So one common cause is less than optimal nutrition. Another can be later puberty. So one reason that children can apparently fall off the growth curve is presuming a typical puberty timing. Well, if an individual is a later bloomer, then they won't have the growth spurt at the same time as their peers, and so will appear to fall off the growth curve. The tricky part about that is it's difficult to know until they have their typical later growth spurt that it will happen. One clue we can get is from speaking with parents and finding out whether or not they come from a family of early or late or typical bloomers. That can give us additional reassurance if a child is following a pattern that's similar for the family. Very treatable non-Friedreich's, but common health problems that can cause growth impairment, like celiac disease or thyroid, certainly reasonable to test for. There are also Friedreich's-related associations with less than optimal growth that are important to ask about specifically. So In the patient we discussed, I didn't mention it, but if you're affected by scoliosis, the higher degree of curvature can mean that the linear growth appears to be less, and people's growth patterns will look different after scoliosis is corrected. Significant cardiac disease is a stress on the body that can affect growth in individuals with cardiac problems with and without Friedreich's. And then evolving diabetes can be a reason for weight loss, and so can also be considered. What do we do in our clinic? We do a physical examination, including with pubertal staging, because especially if a child is at a time of life when typical puberty could be affecting growth, knowing where they are really helps us. We want to make sure they're current with their Friedreich's surveillance, so we know any Friedreich's-related factors are contributing. We also get a bone age x-ray. I mentioned this, as any of you have children who are referred for growth evaluation, we ask for this. Is the x-ray of the left hand. And we have reference values that tell us what typical left hand x-rays look at different ages. The reason this is valuable, you see the various black lines in the long bones. It's easiest to see at the wrist. Those are the open growth plates. And when we see how open the growth plates are, we know how much potential there is for growth remaining. And that gives us a rough sense of the age of the skeleton, of the maturity of the skeleton, and how much of the child's lifetime growing we think they've done. And that gives us a sense of their future potential. So this is another important part of the evaluation. The most common things we do is continue to watch. If we've excluded common treatable causes and we've evaluated the contribution of Friedreich-related factors, then most often we are watching to ensure that kids grow along their own curve, or that there's nothing else that we could be doing to optimize their growth. Continuing to focus on healthful nutrition, make sure they go through puberty as we might expect, address their scoliosis, optimize their bone health, which we're going to talk about. All things that we do. Rarely in some kids with Friedreich's, just like some without, we need to consider additional supplemental nutrition or testing for growth hormone deficiency. So when we think about weight gain, just unpacking that a little bit more, many individuals with children with Friedreich's are underweight by BMI, and we've studied this, and we know the timing of the pubertal growth spurt, which I'm showing you in this chart, is a bit different from typical. In adults, as in adults in the general population, but we see this with Friedreich's as well. Instead of underweight, as is more common in children, overweight and excess weight gain can occur as well. Relevant to the adults who might be listening, we have studied this, and we know that final adult height seems to be affected to some extent by Friedreich's. And the way that's manifest is that folks with more genetically severe disease, so longer GA repeat length on the least affected allele, tend to be shorter. I have a few slides on body composition because we've studied this in the research setting, and I think it's really interesting to mention because we've talked about BMI. BMI is body mass index. It's a reflection of weight relative to height. It's valuable. It was introduced as an epidemiologic tool. It gets used in the office to say, gee, is someone weighing more than they should for their height? But it's good when we talk about body mass index to remember that body mass index is not the same as body composition, right? We want to know how much muscle, fat, and bone is in the body. Our guidelines tend to attribute high BMI to too much fat and low BMI to not enough, but that's not always the whole story. So what I'm showing you here, and what has changed how I think about taking care of individuals with Friedreich's across the BMI spectrum, is looking at fat mass, lean mass, essentially muscle mass in individuals with Friedreich's, which are the white boxes, compared to controls. And the top panel here is in adults, and the bottom panel is in kids. So this is from one of our research studies. When we look at how much fat mass relative to height people with Friedreich's and controls have, it was around similar. But then when we look at lean mass, which is closer to muscle mass, it also includes organs. When we're trying to look at muscle mass, we look at appendicular lean mass, so like arms and legs. Now, the amount that people with Friedreich's have is much less. And when we adjust for the total amount of fat in our body, usually muscle and fat travel together. When we adjust for fat, then the amount of lean mass and muscle mass is much reduced in Friedreich's, even though their body mass index and other indices may appear typical. And a similar pattern we see in kids, the height and the BMI may be similar to their peers, but many kids have slightly higher fat mass, in fact, but much lower skeletal muscle mass. So building or maintaining skeletal muscle is something that we're really focused on clinically and in the research setting. And part of that is because we know there's an association with disease severity and muscle mass. And probably this is related to a couple of things. One is, if you have more severe Friedreich's, then you may be less able to move around and to maintain that muscle mass. We also wonder whether or not anything that one could do to preserve lean muscle mass would help retain aspects of function that would be reflected in the mFARS score, which is a measure of disease severity that you may be familiar with. So going back to Friedreich's guidelines, what do they say? We point out that height and weight should be measured and BMI should be calculated, but it does have limitations in many populations, including with Friedreich's. So again, if there's one point to make, measuring height and weight is really important in these visits. We also recommend that people monitor weight on omaveloxolone. Some of my patients have lost weight, and important to pay attention, kind of know what your trajectory is to assess any implications for your health. All right, switching gears, just spending a few last minutes on bone health. This is another one that's really important. We take care of individuals with fragile bones or fractures in endocrinology. So just a quick primer, bone density changes throughout the lifetime. That's how mineralized the bones are, how strong they are. This is a chart of the lifespan. Bones become more and more dense as children grow. And then even after they're done growing, kids continue to, and young adults continue to acquire peak bone mass. And then bone mass is around stable for a while. You see the difference between males and females. Females experience a drop off around menopause. Men also have a decline over their lives, but it's more gradual. This line here shows what happens if there's suboptimal acquisition of bone mass for whatever reason. So weight-bearing exercise is one really important thing that helps increase bone mass. So if an individual doesn't acquire enough bone mass in childhood or early adulthood, then they may be more predisposed to be in these lower, higher risk ranges later on in their lives. And vocabulary, in case you've had your bone health screened, or you get a measurement done. We'll talk about DEXA scanning in a second, but older adults, right? So once you're in kind of this later stage of life, are compared to their peak bone density of a young adult. So they get what's called a T-score to show how good or bad they are, usually bad relative to where a younger adult would be. And so the T-score is interpreted as normal if it's between anything higher than -1. Osteopenia is a word that people may have heard. Weaker bones, and weaker bones may start to increase the risk for fracture. That's between this -1 and -2.5. And then less than -2.5, it puts older adults into a osteoporosis range. So a less well-mineralized bone is less strong and less able to avoid fracture, avoid breaks. Younger adults and children, we compare them to their age and sex matched peers, right? Because if you're at this phase of life where your bone density is changing quickly, we compare you to people of similar age and size. And the way we do this, we measure the skeleton at several different sites. So I've shown you some of the sites of the skeleton that we measure on our DEXA scanner. So this is from my colleague at UCSF. Some people stand on this, and this C-arm kind of travels over top of you. That's how we measure. It takes around 10 to 15 minutes. Again, the reason we care about this is because low bone density can predispose to fracture. And I'm reminded here, I have a note, fractures can be occult. So sometimes people have what are called vertebral crush fractures, where their vertebrae have become shorter, and their only symptom is back pain. So they may not even realize that something happened. Some fragility fractures can happen without an apparent antecedent trauma, so and without a clear mechanism of injury. This is a good note to mention that DEXA captures bone density, but not quality. So it's not the only feature that affects fracture risk with respect to bone. Fracture risk is really complicated. It also includes how much exposure to trauma there might be. So people who are relatively less active may have lower bone density, but they may also not be engaging in activities that predispose them to fracture. So fracture risk is really complicated. So when we think about what our recommendations are for folks in Friedreich's, balance and strength and fall prevention are really helpful. Any exercise or physical therapy should be pursued with bone health in mind. We like to think about making sure folks get enough calcium and vitamin D3. I've listed some reasonable doses that we often use. We do, especially people who have DEXA scans that are worrisome, measure vitamin D levels. It's also very reasonable. It's one nutrient that is, even in someone with a balanced, healthful diet, living in the latitude where we live. I'm in Philadelphia right now. It's really difficult to get enough. Our skin makes that in response to the sun. It's really difficult to get enough to ensure adequate vitamin D. Certainly, if folks have nutritional problems like celiac or diabetes, there may be reasons to require more vitamin D, or those other nutritional or health factors can affect bone health independently. There's a role for medications. We do have medications to increase bone density and or to potentially prevent fracture. So the intuition we have is that, especially in adults, a very low bone mineral density or any pathologic fracture can be a reason for medicine. And just to be explicit about what that pathologic fracture means a fracture we wouldn't expect to happen based on the mechanism of injury. So if someone's in a high velocity car crash, then if they break a bone, we're not surprised. But if someone falls from a standing height and they break their femur, that's a surprise. That could be considered a pathologic fracture. So in children, the guidelines are a little bit less clear, but in general, we consider medicines, again, for a pathologic fracture, or if children have bone density that's either low overtly, or especially if it's declining, because you saw in childhood, the bone density should be increasing. And if it's low and not increasing, then that's a suggestion that medicine may be helpful, and we individualize that risk-benefit discussion. This is just some data on Z-scores for adults of bone density, where the controls are in red and folks with Friedreich's are in teal. So we know from some of our work and others that bone density is reduced in people with Friedreich's. So this is another reason to pay attention. And we have endocrine and bone health specialists that can really focus on this and give specific recommendations. And the guidelines say consider DEXA scanning in adults who are at highest risk for low bone health, or at high risk for at risk for low bone health, and children at highest risk. This is really related to the availability of medicines. In other words, we want to start looking for the problems in the people who are most likely to deserve treatment. Mostly we relate this to wheelchair use. So once folks have been using wheelchairs primarily to get around for several years, then we know the risk of low bone density increases. We talked about calcium and vitamin D. Safe bone loading exercise is also really important. So this is my last slide, just takeaway points for the group. I hope everyone will remember the symptoms of diabetes and remember to think about it. If there's a change in your health status that could be attributed to that, then to get screened is helpful. And that there's some thoughtful ways to manage Friedreich-related diabetes that hopefully help keep people healthy. Getting heights and weight measurements, especially for kids, is really important. BMI is useful, but it definitely has limitations, and then do attend to bone health. This is a picture of some of us at Rite Ataxia a few years ago. I think they just announced the next Rite Ataxia in Philly is going to be in October. So it'd be great to see any of you there. And I promised you a link to the clinical management guidelines. I hope everybody on this call is familiar. It may be earlier speakers have introduced them, but if they haven't or you're not, then I'm showing them again here. All right. Thank you.
Thank you so much, Dr. McCormack. I think we all learned something today. I
Awesome.
want to go right into our questions. Somebody typed this in the chat. They said they have type 2 diabetes. They were giving me a once a week shot like Ozempic to help control my blood sugar. My gastroenterologist told me, took me off because I have Agilvi syndrome. Now my blood sugar is running higher than it has been. What should I do or take to combat this?
Um, Thanks. So that's it's pronounced Ogilvy, and that just was for you, but like that's a complicated question. I appreciate the person asking. I'm going to do my best to keep my answer general so that folks know what else is an option. The first is, hopefully you have a great endocrinologist who you feel is very collaborative to help brainstorm different options with you, especially if blood sugar is starting to go higher. So like I said, we start with testing anti-pancreatic autoantibodies, looking for insulin resistance to help us decide, like, is this somebody who would benefit from insulin, or is this someone who would benefit from glucose lowering medicines? Now, someone's given the diabetes to this person, they're given the diagnosis of type 2 diabetes, so then probably we're in the frame of other glucose lowering medicines. So some people will ask about metformin. That's a medicine that's been used for a long time that can cause some GI distress in some people. So discussing that with a gastroenterologist who's familiar with the particular circumstances of Ogilvy, which is a GI concern, would be helpful. Metformin comes in extended release forms that are sometimes better tolerated from a GI standpoint. Um, and then SGLT2 inhibitors are medicines that sometimes are helpful for glucose lowering purposes that wouldn't have that same concern. If that's something that people wish to pursue, we do give people with Friedreich's the ability to monitor ketones, like with blood measurements while they're on those medicines so that they can stay safe. And we also screen their residual insulin production with blood tests before we prescribe those choices. So I think you're hearing like each you've already experienced, the person asking questions already experienced this, like each kind of medicine can have some real advantages, but then some drawbacks. So we kind of make our choice based on how those are balanced. That's a super question.
Great. Thank you so much for answering that. How often should people with FA be screened for diabetes or prediabetes?
Yeah, that the guidelines suggest once a year. They should be screened for diabetes or prediabetes. The exceptions to that, sometimes people have symptoms or a change or a positive result on screening that makes us recommend they be screened or tested more often.
Great, thank you. Which tests are best for FA patients? Like A1C versus fasting glucose?
Yeah, good question. So I have two answers. One is the guidelines suggest we get fasting glucose and hemoglobin A1C because we interpret them together. The fasting glucose gives us a single point in time at a standard nutritional framework, so like after an overnight fast, and the A1C gives 3 months. So ideally, we get both. We know for a lot of people, getting fasting blood work is really prohibitive. So I often tell people I'd rather get something than nothing, right? So if you're getting blood work done, a hemoglobin A1C and a random blood sugar is helpful. And then if there are more concerns, we either sometimes give people glucometers to do some random blood sugars at home if they're in a risk range, or in some people, again, in whom we're concerned, we sometimes do like a 2-week continuous glucose monitor just as a check to see kind of where you're at. So those additional tests would be reserved for people who had more of a concern.
That makes sense. Thank you. I think something that comes up a lot is when to be referred. And I know, you touched on that a little bit, but, um, if someone doesn't have multidisciplinary care, when do you think patients should be referred to an endocrinologist versus managed by, say, primary care?
That's a really great question and a difficult one because, as you say, it really depends on people's access to care. I'll say my own bias is anyone who meets criteria for diabetes is considering choosing among medicines. It would be ideal if they could see an endocrinologist, mainly because, the first question illustrates this. Like there's some additional complexities to making that choice that hopefully an endocrinologist could help guide. More and more, especially people out of for whom it's not convenient to go telemedicine, and we're doing a lot of advocacy in the endocrine community to keep up insurance coverage for telemedicine to make it easier to access specialists of all kind, but endocrine is one that really works well with telemedicine. So for people who are farther away, that's one worth considering. And sometimes people will go to an endocrinologist like once a year who will give some guidance, and then their primary care doctors will manage in between, which I think is a good option. A primary care doctor certainly could look at the Friedrich's guidelines and help get started. My own bias, of course, we're happy to see people with, A1Cs above 6, even to just help design a monitoring strategy and to give additional recommendations. That's sometimes a compromise too, is that like maybe, you see an endocrinologist once to get some guidance, and then the primary care doctor goes from there. And some of the neurologists, I know Dr. Lynch is expert in everything, but like some neurologists who, manage care for their patients become familiar enough with getting this screening results that they feel comfortable, continuing the monitoring, for example, for early abnormalities.
Great, thank you. I'm going to ask maybe one or two more questions. This one seemed important. Are there early warning signs or symptoms of endocrine issues that families and individuals with FA should watch out for?
Or yeah, well, I mean, there can be endocrine, covers a wide range of problems. So really the three I chose today were the ones I chose for, that good reason. So high blood sugars and diabetes. Um, what can be tricky about that is, especially as someone is becoming sick, that can be kind of, if they had kind of diabetes brewing, the stress of the sickness on the body can cause the blood sugars to go up. So then you may not be sure what's making you not feel well. Is it the illness or is it the higher blood sugars? And for some people, it's both. So those symptoms of like excess urination, excess thirst, and sometimes triggered by an illness, those people should pay attention to. Growth abnormalities in children always deserve attention. So if a pediatrician is saying the child is falling off their growth curve, that's worth investigating. And then a broken bone, especially a broken bone that where the mechanism doesn't make sense, where it's surprising that they would have had a broken bone. Those are all important. With respect to the broken bone, hopefully we do things before that, because like I didn't say it out loud, but people know like having a broken bone, having to wear a cast, having to change their mobility, that really it's painful, it sets people back, it really gets in the way of their lives. So hopefully we can be a little more proactive about maintaining bone health. We're still working on figuring out the best ways to do that.
Yes, being proactive seems like a very good takeaway. Well, Dr. McCormack, I will let you go, but thank you so much for being here today and for answering all of our questions.
Sure, sure. Thanks so much for having me. I really enjoyed the opportunity.
Thank you.